Hello and welcome to Connect and Collaborate. I am Alex Hopkins, your on-air producer. All week long we have been talking tourism, and today we're taking an interesting turn on our road trip through tourism and outdoor recreation in Colorado. We are turning to Arlen Meyers, and he is going to tell us all about medical tourism. Arlen is the co-founding president and CEO of the Society of Physician Entrepreneurs, better known as SoPE. And we also have with us Professor Blair Gifford from UC Denver. Hello, gentlemen. How are you today?
Hi, thanks for having us.
Yep, thanks.
Yeah. So, Arlen, it's been a little bit since we've had you on. Can we get a little bit of your background here for our listeners?
Sure. So, as you indicated, I'm with the Society of Physician Entrepreneurs, which is a global nonprofit biomedical and clinical innovation and entrepreneurship network. And basically, our mission is to help our members get their ideas to patients, commercialize their ideas. We do that through an international chapter network, and we're at SoPEnet, SoPEnet.org. And as part of my, I'm an emeritus professor at the Anschutz Medical Campus. My background is as an ear, nose, and throat facial plastic surgeon. I no longer practice medicine, but I full-time now sort of practice physician entrepreneurship.
Which is an interesting take, right? Physician entrepreneurship, it's not something you would put together right away.
Right, yeah. It's a different, actually we're trying to establish it as a separate academic and practical domain. But the good news is that we officially launched SoPE in January of 2011. So we've been at this now for 7 years. And the good news is we're seeing more and more engagement and activity.
Fantastic. Well, one of the connections that you made here is with Professor Blair Gifford. Is that correct?
That's correct. So Blair, why don't you tell them a little bit about yourself?
Okay, my position at the University of Colorado is I'm a professor of global health management in the business school. We have the MBA health programs, and we have a lot of physicians who are very interested in things like entrepreneurship, taking those classes. I personally have been working in China since about 2003. More recently, I've been working in Haiti since about 2007. At the university, I started the Center for Global Health. That's more about healthcare in developing nations, sort of on the humanitarian side. But I am involved on the business side, too, primarily in the China realm of things. I guess that's a good start.
There you go.
Yeah, we've been collaborating as part of our efforts to create links between the downtown campus at UCD and what is now the Anschutz campus. We actually started this when we were at the old campus at 8th and Colorado Boulevard, so we've been at this for a while.
I live right by the Anschutz Medical Campus. I always get worried that I'm going to get pulled over there because it's only 25.
It's a speed. Right.
So you know what I'm talking about.
I know what you're talking about.
Yeah,
right.
I immediately turn in there and slow down, you know.
Right.
So you said you've been working together for 7 years?
No, we've been working together for 20 years, something
at
least a long time.
Right.
Creating collaborations at universities is a long-term project, so we've been at it for a while. Yeah.
So what's been born of that? What's some of your successes there?
Well, Blair, why don't you...
Well, first off, we tried to develop something back in the early 2000s. We didn't get the political support we needed at the university, so frankly, we sort of went on our own ways. And as such, we've sort of continued to develop things, and now we see the university actually coming to us and saying, hey, we need you to do what you wanted to do back in, say, 2002. And so we're starting to see things develop right now, although a lot of it's sort of talk right now. We don't have anything in particular that we have that's an established partnership, but I can imagine, for example, the business school doing a lot more with the Anschutz campus out in Aurora here in coming months.
Well, actually, there are several collaborations that are evident. One is, for example, our Certificate in Bioentrepreneurship program, which is a certificate offered by the JAB Center for Entrepreneurship, which is a part of the UCD Business School. Blair and I have cross-collaborated in terms of speaking at each other's courses.
Okay.
I've participated in his course at the business school. He's participated in our courses at Anschutz. So there's some knowledge exchange between faculty across campuses. There are multiple experiential learning opportunities for students at both campuses. And more recently, there's a potential to do more collaborative entrepreneurship education and outreach. And we can talk more about that some other time when it's riper. But there's a lot of things that I think we've have accomplished over the years. We certainly like to do a lot more.
Well, I should add, so yes, you're right. Arlen's brought a lot of the entrepreneurship to the business school, especially in the bio realm. At the same time, I'm more on the international side, and there's quite a bit going on at Anschutz right now. It's all developed in the last 5 or 6 years. We have quite a bit of international going on in the business school, but we really haven't gotten the forces from both sides to meet, to work together, and yet there's tremendous opportunity. So I imagine here in coming months it's going to all happen.
And I think this program is really about what's happening when bioscience and bioentrepreneurship collides with international business.
Wow.
And
right.
And how does that create opportunity? And I think that's what we're going to talk about.
Right.
Fantastic. I love that. It's definitely a different idea, right? It's not something you don't necessarily think medical and entrepreneurship together.
Well, that's not exactly true. But so, for example, when you look at how medical devices get commercialized, how drugs get commercialized, more recently, how digital health products and services are becoming more part of clinical medicine, how platforms, care delivery platforms, are evolving. These things tend to be global.
Right.
And in many instances, there's a phrase called born global, where a startup company literally is started in a Starbucks and is a global company, where you have a developer in Estonia, you have a sales and marketing person in Asia, you have scientists all over the world. So it's a virtual, born global company. Now, when bioscience meets international business, and more specifically international entrepreneurship, a separate subdomain of international business, and you add that to social entrepreneurship, then things start to get pretty interesting. So then it becomes a social enterprise colliding with international entrepreneurship, colliding with bioscience. And that's why it's important for us to collaborate, because one particular institution can't do it all. We don't have that expertise. He does. I may have more expertise in bioscience, but running a hospital in China is not something that I know how to do that he can help with.
Okay.
And that's what we're trying to inform our students about.
And I should like to add, I'd like to add that this isn't sort of driven by us. This is actually being driven externally by other countries who are looking to develop their health sectors, both on the biotech side, but also the health services side, for a variety of reasons which we can talk about. And so they're asking, and America, quite frankly, when it comes to healthcare, is seen as a world leader.
Yeah.
And in many capacities. So these countries, they want to come up to speed. So who do they go to? They come to America. So they're the ones that are asking us to come put things together to bring to them. And it's an interesting phenomenon. It's all happened in the last 5-10 years.
And so maybe we can talk about, what are the drivers that are making this happen? And so this program really is about what we're calling medical travel, medical tourism.
Right.
So maybe it would be useful for the listeners to kind of, what does that mean?
Exactly.
And I'll just start it off, and then Blair can fill it in. First of all, the term medical tourism, I think, is an unfortunate misnomer, because, as we all know, having surgery is not a vacation.
No.
So this is not about sitting at the pool bar drinking margaritas while somebody's fixing your whatever. It's serious business. So
right.
we would prefer to call it, it has a sexy marketing hype.
For sure.
And it grabs the headlines, and it's a good SEO term, but it really doesn't describe what we're talking about. We're talking about leaving home for care. So leaving home for care, and typically that care is episodic. In other words, it's to get an operation, it's to get a relatively short episode of care. You may go somewhere to get treated for a particular illness with a certain intervention, but you're going to live there for 6 months while you're getting treated. So it's kind of an in and out kind of a thing.
Now, I just want to define leaving home, right? This can be across the ocean, but
so
it can also be...
Right, so that's a good point. So what does that mean? Well, it could mean we're generally not referring to you're leaving Denver to go to Lakewood.
Right.
We're talking about leaving Denver, let's say, within a 2-hour travel radius.
Okay.
Just to create an arbitrary line.
Right.
So whether that 2 hours is driving or flying, so if you drove from Denver to someplace else, to Santa Fe, that may be 4 hours.
Right.
But you could get on a plane in Denver and go to Kansas City.
Yeah.
And that would be 2 hours.
Right.
So that's kind of what we're talking about.
Gotcha.
Now, you could fly from Denver to Kansas City, or you could fly to Denver to Oaxaca, or to Cancun.
Yeah.
And that's still 2 hours.
Yeah.
But so one definition has to do with the time or the location that you're going to.
Okay.
And there's generally, it's described as inbound, outbound, or domestic.
Okay.
So inbound means that a patient from China with cancer comes to the University of Colorado or to University of San Francisco, whatever, to get treatment. So that would be inbound in reference to us as the inbound host.
Gotcha.
The outbound means you go to Thailand to get your hip replaced. Or you go to Cancun to get some orthopedic operation or that kind of thing. So that would be outbound. Domestic means you're a U.S. citizen or a resident, and you go somewhere in the United States to get care. Now, this could be a person in Kenya who is a Kenyan getting care at a center in Kenya.
Okay.
So that would be domestic medical travel in Kenya.
Okay.
It just depends on where you live and your country. So
Yeah.
those are the kinds of things that we're talking about. So what's driving that, and maybe Blair can comment because he's literally done a lot of work in China, in Haiti, more recently in Kenya, and other places around the world.
Yeah.
So maybe, Blair, you can comment on what's driving the need for care or the perception of the need for care in the United States, that is inbound tourism or travel in reference to us as the host site.
Well, first off, the internet's made a big difference.
Yes.
People are much more aware now of what is out there and what is available. They can certainly look at quality of care, but they can also even look at pricing. And with the pricing, some people can, if you're going outbound, and I know you want me to talk about inbound, but if you're going outbound, Americans going to Thailand, it's about 20% of the cost of a procedure here. In India, it's actually almost 10%.
Wow.
So, and they have state-of-the-art equipment. They have people that are very, very well educated, so you can often get very good care. And insurance companies, in some cases, have an international package where I could maybe pay a lesser premium for my family, and when I need some care, like bypass surgery or something like that, I have to go to India and have my care done for 1/10 of the cost of what would have cost here in the U.S.
Right,
and I probably get a bonus back and all that kind of thing.
And a lot of the doctors in India have been trained in the States, right? So you're
That's
getting,
exactly right.
Yeah, you're getting that same
exactly
medical
right.
care.
Right.
And that's the outbound side. On the inbound side, you'll find places like in China. China has an epidemic, and I'm not understating that. It's an epidemic of cancer. It's rising exponentially. Breast cancer, colon cancer, stomach cancer, lung cancer, pollution, etc. The Chinese have about 1/4 the capacity to deliver that kind of care.
Wow.
So they're trying to come up to speed, but this doesn't happen overnight. This is going to take 5, 10, 15 years, not just in terms of human resources, but just getting the knowledge base to understand what the kind of care they should be giving. So therefore, Chinese are now flooding to other countries. Last year, according to the New York Times, 500,000 Chinese flew to Taipei, Taiwan to get cancer care.
Wow.
And they're also going to Seoul and Singapore and Bangkok, etc. They're also coming to Los Angeles and San Francisco. The Chinese now realize what they need to start doing for cancer care, and they need to do it earlier on so they aren't in stage 4, but maybe stage 2. And so their families are getting together, putting money together, and they're sending their elderly uncle or what have you to San Francisco to get the care.
Right.
And so people in San Francisco are building up concierge services to help the Chinese and sort of Mandarin and family services, etc. So it's going both ways. I mean, the Chinese are traveling and we're traveling, and the various locations are developing the international capacity to handle these kind of people. So yeah, healthcare is really globalized.
And fundamentally, people do this. I mean, if you think about it, leaving home for a major operation is a significant decision.
Absolutely.
And most people don't want to do that. I mean, let's face it. You would rather stay home. You have a support system with family and all that other stuff. But some people find themselves in situations where they think it's a good idea to do that.
Yeah.
And the things that usually drive that have to do with what I call a push-pull arbitrage. In other words, I don't have what I want here, so that's pushing me to go to a place that does have what I want.
Yes.
And those things that I want typically have to do with quality, cost, access, and experience.
Right.
So I don't have the money to get my liver transplanted in Los Angeles, but I may be able to go to India to get it done. Or I don't have the money for the copay and deductible to have a hip replacement done somewhere in the, so I'm going to go to Cancun or some other place to get it done. So that's basically what's driving this activity. But the fact of the matter is, the medical travel industry, and it is an industry, sometimes overstates how big this industry is and the number of people that are traveling around the world.
Okay.
And so I think for listeners, you need to be careful about the hype versus the reality and the risks and benefits of doing something like this. Now, another point is that one of the hats I wear is as the chief medical officer for a company named Bridge Health. So as an example of what's driving domestic medical travel, and in some instances outbound, has to do with so-called value-based surgery. In other words, quality per unit cost. So essentially, we're sending people to high-quality surgeons as measured by a third party for a bundled price, and there's lots of advantages to taking advantage of that if that's something that you want to do. So it's an example of how businesses can lower their cost by taking advantage of something like this or other applications. Now, as Blair mentioned, some people are looking more into, for example, workers' comp and trying to lower the cost of workers' comp payments and outsourcing them, or in a sense, sending patients to places outside the United States that are cheaper. There's another issue of, for example, should Medicare pay for treatment for someone like me on Medicare in Mexico if the quality is better or the same as what we can offer here for a substantially lower cost. Now, the political question is, do you want to outsource Medicare to Mexico? And even though it could be cheaper and offer higher value. So a lot of these things have to do much beyond the medical questions.
Yes.
And maybe, Blair, you can share some of your, because a lot of it has to do with geopolitical questions as to who gets involved in this and how these things happen. So maybe you can share some experiences.
Yeah, we've been talking a little bit about patients and insurance and things like that driving this. What's interesting today is how governments are now starting to drive this. For example, I was just in Kenya, as I was talking to Arlen earlier, for the last month doing some work, and a lot of Kenyans are getting visas and traveling up to Mumbai or what have you in India to get their care at Fortis or Apollo Group, and this isn't good for the Kenyan government. First off, they're losing a lot of that income, but it also means the doctors aren't seeing these private patients in a lot of cases, and what's happening is in many countries there's tremendous brain drain. The physicians are leaving the country and going to places where there's more money available for patient care, and what happens is it just these countries are losing doctors, they're losing patients, so they have to rebuild their healthcare system, and they bring in state-of-the-art equipment, they have an international hospital, they're trying to attract doctors, etc. We're seeing this in Nigeria, we're seeing this in Kenya, we're certainly seeing this in China, and many of these countries are trying to get back in the game.
Right.
Because they can't afford to lose the patients, they can't afford to lose the doctors, etc. So they're actually investing in medical tourism, if you will, or the globalization of healthcare, partially in a defensive way, because they need to come up to speed to keep people inbound. And if they can do that, then they may actually become a destination. And if they become a destination like Kenya is trying to do right now for Central Africa, then that's going to bring a lot of revenue in terms of, patient care, but tourism generally, etc. And more doctors are going to come in. Realize that virtually all nations around the world, there's a dearth of human resources in healthcare. They need more doctors everywhere. In some countries, they only have one quarter of the doctors they need, and maybe only 1/10 of the nurses they need. They can't afford to have more brain drain, people leaving the country. And let me just give you one example. In Ecuador a few years ago, there was a World Bank project to build 2 world-class hospitals. One was going to be children, one was going to be general services. One was going to be in Quito, one was going to be in the suburbs. And it was all about brain drain. They were losing their physicians to Peru and to Colombia, and the patients patients were going to these other countries, they need to come up to speed. So the government was investing into these medical tourism hospitals. That project sort of fell apart. They had $750 million available to do it, but the World Bank sort of backed out on that project for a variety of political reasons. But that project, if you could, take that project and multiply it by 25 times, and you got an idea of what's going on in the world. These governments are investing in international health services.
Some other issues that come up have to do with, so what should, for example, what should a patient or a business who employs a potential patient know about medical travel?
Yes.
Should you go or shouldn't you? Should you include it as a benefit? Should it be mandatory? Should it be elective? And I think there's a couple of things that we need to mention. And we're talking about kind of the intersection of the medical parts and the business parts and the hospitality parts. So I kind of lump them together where these things come together. Obvious risks from the medical part has to do with the things I mentioned: quality, cost, access, and experience. The fact of the matter is that there is, in my view, there is not a global care ecosystem that would allow a patient to go anywhere, anytime, any place, and get access to affordable care at a reasonable price. So I don't think that system has evolved. And the example I would give you is, it's hard enough to go to see a doctor in Denver and transfer your records to a doctor in Lakewood. Mm-hmm. Imagine what it's like trying to get your records from any place else, Central Africa, mm-hmm. and then come back to Denver and expect to get those records to a follow-up doctor. So there's an issue of global health IT interoperability. Mm-hmm. There's an issue of global IT cybersecurity. Mm-hmm. There's an issue of handoff drops. In other words, who's going to see you before, who's going to see you after, let alone the quality. I think actually the quality of care is pretty similar around the world if you go to the right people.
Right.
I mean, obviously there are differences in Denver. But if you find the right person and there are ways of doing that, then I don't think the quality is the issue. So I think that's an issue. The second has to do with the business model. Who pays for what when?
Right.
And the third has to do with the hospitality part. Where are you going to go and stay? Is it going to be done in an ambulatory surgery center? And if so, is there a hotel? Is it a 5-star resort? Is it a bedroom of some guy at an Airbnb? I don't know where you're going to stay after this thing.
Right.
So those are the considerations that I think patients need. And there's the medical liability issue. So right. Unfortunately, it's a reality in the world of medicine. And if something goes south and you decide to sue a doctor in Quito, Ecuador, good luck. Now, you may win, but it's going to, who's going to do that? It takes forever. It's going to cost, and even if you win, how are you going to recover any damages? So I think that these are things that people need to seriously think about when it comes to getting care. And the other issue has to do with equity. Mm-hmm. And so maybe, Blair, you can comment on this. So the assumption is that if you're a government, mm-hmm. and this applies to Denver, and maybe in the next segment we can talk about this. Suppose you're a government and you decide you want medical travel to be an economic development driver of your city or your state or your country. The hypothesis goes, it's a trickle down. Mm-hmm. If we can get so-called rich folks to come, then the locals are going to benefit. And we can talk about that in the next segment.
Absolutely. I am here with Arlen Meyers, co-founding president and CEO of the Society of Physician Entrepreneurs, and Professor Blair Gifford from UC Denver, that's the University of Colorado, Denver. We will be right back. Stay with us here on Connect and Collaborate as we continue our talk on medical tourism. Welcome back to Connect and Collaborate. We're having an exciting conversation here focusing on medical tourism. While I know all week long we've been talking about tourism and outdoor recreation here in Colorado, which is something everybody loves, we took a different turn on our road trip of tourism to talk about medical tourism here with Arlen Meyers, co-founding president and CEO of SoPE, that's the Society of Physician Entrepreneurs, and Professor Blair Gifford of UC Denver. So we were just talking about medical tourism and the cost, right, of it coming sometimes in our economies, medical tourism can help, right? Let's start where we left off in our last segment.
So let's kind of talk about the business opportunities that are presented by medical travel. So for some listeners that are saying to themselves, well, that's kind of interesting, so how do I get in this game, and how do I make money, and what are the risks, and all that business? So let's talk about that. And one question is, should Denver, for example, or the region, be a center for medical travel? Right. Should we position, we meaning the state, the public-private partnerships, all the stakeholders, should we try to position Denver as a medical travel destination formally? And this applies to Nairobi, it applies to China, it applies to however big you want to draw the map.
Right.
And the benefits and risks of doing that. So Blair, let's start with this question of, so one of the traditional arguments by governments, and there are many governments around the world that have tried to do this, I would remind you that 5 of the fastest growing economies in the world are in sub-Saharan Africa. And so increasing middle class growth, access to disposable income, demand for higher quality care and services is in part driving, and if you don't satisfy that, it creates social upheaval. So there's a political reason to do this, and that is because you don't want to get fired or assassinated or God knows what, because you haven't satisfied the need of the people, and you haven't shared the wealth. So there's this equity piece. So the argument goes, we're going to create an economic development zone in our area, and by encouraging people to come to that zone for medical travel services, we will recognize the income and share that wealth with the local population, which in a lot of instances is very rural. So we're going to use the money to develop the infrastructure of the country. So Blair, does that argument make sense based on your experience?
I know there's a lot of cynicism about development overall for the country when they develop some international private health services. But let me start and actually go against that cynicism. So we did a survey, actually a couple surveys. We surveyed doctors in Brazil, Mexico, India, and also in Thailand about medical tourism. When we surveyed doctors that are both in the public health realm, at a public hospital, and at the private hospitals. And in many cases, the physicians worked in both. They would work at the public hospital in the morning and see some private patients in the afternoon at, say, the International Hospital. Much to our surprise, and against our hypothesis, I should add, we found that the doctors were all in favor, for the most part, of international or medical tourism. We were really surprised at that. And they actually thought it was good for the country and that services were improving overall for the country because you have an international hospital with high standards, the best state-of-the-art equipment. These physicians are working maybe both in the public and the private realm, but they go back to the public realm and they take their experiences in the international hospital and they apply them out in the public hospitals. And the country is not losing doctors. They're seeing doctors actually come to the nation to work, etc. They become a destination for tourism. So overall, the economy's picked up, etc. So once again, we were surprised in our survey results, and we actually took these to journals, and the journal editors said, wait a second, you're wrong. This is actually hurting the public health of the nation overall. And I said, well, that's not what the doctors said that are doing this in these locations. So for me, it's hard to actually say that this is benefiting the country. But on the other hand, that's what these doctors in these countries have said, and who am I to say they're wrong?
They're living it firsthand.
Well, I guess there's a difference between what benefits the doctor and what benefits some person living in rural Ethiopia who has no access to care when it's all being done in Addis Ababa. And how does that trickle down into the local region?
Well, I'm going to, go back to the fact that once again, you've stopped the brain drain. Doctors aren't leaving, patients aren't leaving, they're going to other countries. You're bringing in state-of-the-art equipment, you're bringing up medical education, and somehow, yes, it is trickled down, but it is somehow arguably spreading throughout the nation and raising the ocean, if you will, in that nation in terms of health services overall. we don't have any real case studies like in Thailand that has shown this to actually be the case. But that's what these doctors have said. And I think some of these, these doctors are sensitive to public health. Many of them got into healthcare to help all patients, not just those with money.
Yeah. And the fact of the matter is that whether it does or it doesn't, it's happening.
Right.
So, so I mean, you can argue, does it or doesn't it? But for example, and maybe again, Blair, you can comment. We're seeing multiple examples of so-called marquee healthcare systems exporting their brand around the world.
Right.
UCSF, University of Pittsburgh, Harvard, MIT, Cleveland Clinic, Mayo Clinic, etc. Mm-hmm. So maybe you can share, Roswell Park, maybe you can share some of the experiences of, what's driving that and what has been your experience with that.
Yeah, I really think this is a topic that is unexplored right now. Someone should write a book on it. Maybe you and I should write a book on it. But it's interesting. The major health players, like CU Health is a major health player, certainly in the region, but Pittsburgh and Harvard and what have you, they've done well regionally. They've established a brand name, and American healthcare is perceived as the top healthcare in the world. Yeah. And so other countries are trying to get American healthcare enterprises to come over there. Well, Harvard and UCSF and MD Anderson and Mayo, they realize the game isn't just in America anymore. They need to take this brand that they've established and make it global. Mm-hmm. And they are going globally. They may lose some money up front, but overall, in time, they may hopefully be one of the top players internationally. We have the Apollo Group out of India. They have gone very international. They've established themselves throughout the world, in the Middle East, etc. And in effect, the Americans are responding to that and are starting to do the same thing. So the playing field has changed. It's gone from local to regional to domestic, and now it's going international. So we're not quite sure what the business value is how this is all going to play out, but this is clearly the direction it's going.
I also wouldn't be surprised, and the same can be said in Asia or the Middle East. The Cleveland Clinic in the Middle East, or Samsung Innovation or Medical Center in various other parts around the world. These health systems are becoming, like everything else in the world, internationalized. Mm-hmm. So that creates challenges and opportunities for patients, for doctors, for business people, for entrepreneurs, for money, for technology. And I would say that people, technology, and money go wherever they're treated best.
Right.
So if you're treated better in Thailand because of XYZ, mm-hmm. there's this push-pull phenomenon, and if you figure, gee, the benefits outweigh the costs, I'm going to go there. In some instances, one of the drivers of medical travel is secrecy. In other words, I could go somewhere and get something done and not have to tell anybody if I'm
Right.
going to pay for it at a cost. Or access to a technology that for whatever reason is not available, for example, in the United States, like a stem cell treatment for XYZ that has not been approved by our FDA,
Right.
or may not have been approved by anybody's counterpart to the FDA, but people are desperate.
Right.
So I call that desperate care. So they go wherever they think there's hope or opportunity for a treatment that may or may not be
Right.
clinically validated.
Mm-hmm.
But that conversation's going on in the United States now with how come we can't try stuff if it's up to us and it hasn't been clinically validated, maybe it can help me. So we're starting to see some blurring of the borders with this business. I also wouldn't be surprised if a place like Apollo in India, who is not constrained by the business model of U.S. medicine, comes to the United States and sets up a hospital that just does hearts.
Right.
Which they do. Mm-hmm. They do a lot more than we do in one hospital. That's all they do. Mm-hmm. And you could call it McDonald care, but there's a lot of benefits to standardizing and routinizing a care pathway where that's all you do.
Right.
Because the numbers seem to indicate the more you do, the more practice you get, the better the outcomes.
Absolutely.
So you may start seeing, and there are models of that, Schuldeis that just does hernias.
Right.
An Apollo hospital that just does hearts, a given place that just does hips.
Right.
So you may start to see those models infiltrating into the United States. Mm-hmm. So it's a different care model, it's a different care pathway, it's a different business model.
Right.
And from the hospitality standpoint, they'll hook up with with Hilton or whomever,
Yeah.
and create whatever they want to create in terms of the experience. So I think the good news is the United States healthcare system, despite all our troubles, will be informed by these international competition.
Okay.
Let alone the fact that there are very large populations of foreign nationals. I'm not talking illegal U.S. citizens, people who live in the United States who came from another place, which pretty much describes all of us.
Yes.
Huge populations of Central Americans who want to get care in a place that totally speaks Spanish.
Yeah.
In Chicago.
Right.
That kind of thing. So I think we're going to see more and more of this cross-fertilization, and I think that then introduces all kinds of entrepreneurial opportunities.
I agree with all that, Arlen. I would also mention, though, we already do have some examples of centers of excellence in the United States, like the Texas Heart Institute. You mentioned Shoalice, they're up in Toronto, but in effect, that's almost like the United States since it's so close. So we are setting up these centers of excellence, and they're being developed all around the world. And it is putting a lot of pressure on, I wouldn't say pressure, it's changing our mind, our focus here in the United States. And we're starting to realize, for example, our FDA is hopefully going to start approving drugs quicker, hopefully in an efficacious manner, but still, because the Chinese FDA, in effect, is approving drugs faster, okay? So, people are starting to do their clinical trials over there and things like that. So it's putting pressure on the Americans to sort of pick up the pace. But as I say, we're very fortunate because America is perceived, and actually probably is, the leader in health services when you look around the world. And yes, we do have problems with our healthcare system, but when it comes to quality of care, American healthcare, our educational system, etc., is fantastic compared to the rest of the world. So we're sort of the envy, if you will, of the rest of the world. So there's a lot of interest in trying to get Americans to come over to a place like China to help develop the Chinese health system so they can get up to speed and not lose patients and doctors elsewhere, etc.
And just to follow up on that, this point of the U.S. healthcare graduate medical education system being the envy of the world, I think in general that's true. We've both traveled around, and I've spent time in foreign hospitals training foreign residents, and they would give their right arm literally to be able to do a residency in the United States for multiple reasons.
Right.
Not the least of which is they get a lot more experience under supervision. But in most non-U.S. training programs, now this is changing, and more are adopting a U.S. graduate medical education training system, but our surgical resident and medical residents get arguably more experience and are the envy of other education systems. So one of the things that's driving this is exporting the U.S. graduate medical education brand, and that's so it has to do with faculty exchange, it has to do with fellowships, it has to do with training people that train the trainer kind of things. There's lots of that going on around the world. And the health administration piece. So as you build these infrastructures, wherever it is, you have to have people that know how to run the hospitals.
Yeah.
And so there's a demand for, now you may argue that, gee, the people that run U.S. Healthcare System, Inc. haven't done such a hot job of running the U.S. healthcare system.
What?
And maybe they like their paychecks, but they really haven't done such a hot job. So it's the blind leading the blind. But we could argue that, well, we've had some experience in building these large systems, integrated delivery networks.
Right.
We're sort of, sort of feeling our way through health IT, all that business, and that's a whole nother issue with how do you integrate health information, as I've alluded to before, health information technologies around the world and make them interoperable and secure them and make them confidential and all that business. So the bottom line is that the good news is that I think as an entrepreneur, competition, integration, decentralization of care, internationalization, all that business I think is driving what ultimately should be the objective, which is delivering patient value.
Right.
So all of this, let's not forget, is about helping patients, not necessarily making everybody a lot of money.
Right.
Sure, we can do well by doing good, but the point is, how do we improve global access and improvement? And I would just point out to you that, and again, this is a reference to the African thing. Surgeons around the world have identified that there is an unmet surgical demand. In other words, if you need an operation somewhere in the world, what's the likelihood that you're going to be able to get it? And the last study was less than 5%.
Wow.
Around the world.
That's alarming.
Yeah, it's a lot.
Yeah.
So there's a lot of this inequity.
Yeah.
In access. Now, you could make the same argument in the United States.
Right.
I mean, there are neighborhoods in Denver where if you need an operation for whatever reason, you can't get it.
Exactly.
But when you look at this on a global scale, the issue really has to do, so in the best of all possible worlds, like I said, it's like world peace and get rid of poverty and hunger. It's one of those UN Sustainable Development Goals.
Yeah.
So how do you set up a system around the world so that anyone, anywhere, anytime, any place could get access to quality care at an affordable price? That's the challenge. It's a wicked problem.
Yeah.
Because as Blair pointed out, the demand for care around the world is almost infinite. The supply is limited.
Right.
How do you balance the two? And maybe you can so what do you how are these various countries trying to do that?
Well, one thing is, and I'm going to go back a little bit to something you said about 5 minutes ago. So when it comes to hospitals, most all health systems in the world are government-based hospital systems. We aren't. We're sort of a public-private mix. But as these countries are trying to enhance their health systems, they've actually started to privatize elements of it. So in China now, they allow for private hospitals. Physicians can work in multiple locations, often taking on a private hospital. The problem is the people that run the hospitals, since they haven't developed a health administration profession like we have here in the United States, and this is alluding back to your graduate health education model, is these hospitals don't know how to compete, and they have to learn how to compete. They have to learn how to come up to specifications and standards, and therefore they're looking to America in that realm too to also come up to speed.
I want you to comment also, because we've had this conversation repeatedly. That is, when you have students in your program, I think it's fair to say that 20 years ago, how to run an international hospital was not in the curriculum.
I would imagine not.
First of all, it was called health administration, and this whole business of administration versus leadership, innovation, as kind of entrepreneurship has changed.
Yes.
So there's the point of how do you teach people, or what do you teach people now? Maybe you can answer that in terms of competing on an international stage. So you're working at the University of Pittsburgh, and they knock on your door and say, guess what? You're going to open a hospital for us and wherever outside the United States.
Right.
How do you train people to do that?
Well, first off, I mean, the first international hospital, arguably, is Bumrungrad Hospital in Bangkok, Thailand, that opened its doors in 1997 when Kurt Schroeder from Tenet in California went over there, and all of a sudden the Thai baht devalued by 50% overnight. So to keep the private patients coming to the hospital, he had to open up and become an international hospital. Well, the thing is, in Thailand and in places like China, so in hospitals back, and actually still going on today, for the most part, they don't have a health administration profession. So they have a CEO that's actually a clinician, a doctor, who rotates in on an annual basis while still seeing putting 50% of his time towards patient care. He doesn't know anything about financial management and strategy and marketing and all the operational things that you have to put into place regarding quality care and patient satisfaction. And so they have to start developing this in other nations. So someone like Kurt Schroeder from Tenet, he just walks in there with all this skill mix that he's already developed in California, and bingo, they got better health management compared to any other hospital in Thailand overnight. And that's exactly what's going on. They're taking these healthcare administrators from America and other places too, France and Italy and Japan, and they're putting them into place in these international hospitals. And, I mean, they're great. There's nothing in comparison. And so there's a lot of catching up happening in other nations. And once again, not just the clinicians and the medical devices and the pharmaceuticals, but actually the health administrators, they're bringing them into country to try to come up to speed. And it's an ongoing thing. So
I'd also like to mention this issue of so-called centers of excellence, like COEs. I mean, you hear that term a lot.
Yeah.
And I have this maybe somewhat cynical view that a lot of centers of excellence are neither centers nor excellent. And so what I mean by that is that a center typically creates the image of, well, we got a bunch of folks working together.
Right.
They're like interdisciplinary, they're cross-professionals. In the case of, say, for example, in orthopedics, there would be a prehabilitation person, like getting you ready for the operation. And then there's the surgical team, and then there's the post-op rehab people, OTs, PTs, all that stuff. Well, in a lot of instances, they're not centers. They're just a bunch of doctors doing the same thing. And they just aggregate them into a place, and they call it a center. Now, true, they may focus their patient mix and their procedures on a given procedure, whether it's a hip or knee replacement or whatever. But in a lot of instances, I guess what I'm saying is, be a little bit skeptical when someone says we're a center.
Right.
Now, when they say they're a center of excellence, that even gets even more complicated because, for example, in the world of medical travel, how do you know that the doctor in, let's take an example, in Mexico, or an American doctor going to Mexico, and that's another interesting model.
Yeah.
Well, for example, what we're seeing now is there's kind of two models where, so the patient is in Denver. The doctor is in Denver. You come to see the doctor in Denver, and the doctor says, you need a knee operation. You need a total knee replacement. But I can't do it in Denver because it's prohibitively expensive and you couldn't afford it. So they go to a third place, actually a second place in this case, and let's just say they go to Mexico.
Yeah.
The hospital in Mexico can provide the platform to do it cheaper. So the two of them go to Mexico, have the operation, stick around until things get better, theoretically, and then go back home and see each other in continuity of care. There's a separate model, which means patients in Denver, doctors in Florida. They go to Colombia.
Okay.
And they both meet, same reason, cheaper place, immaculate hospital, terrific place to stay. They show up, they have it done, but they go back to two separate homes.
Okay.
And that creates all kinds of issues.
I would imagine.
But those are models that we're seeing more and more. So I guess what I would say is be a little circumspect about a center of excellence. And the final point is measuring the quality of the surgical outcome is extremely complicated business. There is no one magic bullet that can tell you who is the best. And tell me about the outcomes of your last 1,000 patients.
Fantastic.
With meaningful outcomes. I don't mean, does your facility have valid stickers on your fire extinguishers? I'm talking about outcomes and impact and quick back to work, pain relief, relief of symptoms, surgical site infections, inappropriate readmissions, that kind of stuff.
Absolutely.
Yeah.
Thank you so much, gentlemen. This was a great conversation. You can find this podcast and more at cobrt.com/radio. Look up Arlen Meyers. You'll find all of his shows there. Thank you so much, gentlemen. It's been a pleasure having you on.
Thanks for having us.
Thank you.
And I hope your audience appreciates what we discussed.
Absolutely.
Yeah.
Have a great day.
Thank you.